All right, for the second part, we're just going to look at some various cases that involve polyostotic tumors. We'll just put the case up, give you a chance to think about the case, how you would describe it, what you would say about it, and then any differentials you might come up with that you think apply to that case. I think early on when you're starting out trying to describe a bone tumor, we talked about a lot of the different things you're supposed to look at, and it can be kind of confusing to keep them all straight in your mind. And so when especially if you're taking a case in conference or something, you don't want to just kind of babble a bunch of words like lytic, geographic, fracture. You would like to actually string them together in some kind of English proper sentence. Um, and so sometimes it helps maybe to write down your description so you can organize your thoughts better before you just kind of babble out a bunch of words when you're taking a conference. So, but we'll go through these cases. All right, so this is the first case. We saw this case earlier. Um, so we have a permeative lytic lesion involving the distal radius with this aggressive periosteal reaction about the distal radius and ulna. I don't actually see any lytic lucencies in the ulna itself, so this periosteal reaction may just be from the surrounding infection. This was a patient with osteomyelitis. The next case, so we have CT scans, two axial scans through the pelvis, axial through the shoulder, and then a sagittal also through the shoulder and the scapula. Now we see multiple geographic lytic lesions. They have a narrow zone of transition, sclerotic border, and there's some faint matrix, especially in the one in the pelvis here. Um, this is not a slam dunk for anything. This patient didn't have any underlying malignancy. They were a young patient, so they look fairly benign. So you can think about benign things that cause polyostotic conditions. And these turned out to be multiple enchondromas in a patient with Olier's disease. So next case, so we have axial non-contrast CT through the pelvis. You can see here's the lesion right here. So the lesion is actually arising from the pubic symphysis, and there's an associated soft tissue component and some faint, probably chondroid matrix within the soft tissue component. This patient had other lesions in their body as well too, and this was an osteochondroma arising from the pelvis that actually had undergone malignant degeneration. And so this soft tissue component is part of the cartilage cap and the expansile soft tissue component, which looked quite worrisome. So this was a patient with multiple hereditary exostosis who had a malignant degeneration of an osteochondroma. So chest x-ray, not showing you this for the lungs, so look at the bones, see if you see any findings. Symmetry is your friend, so look from side to side, and as we're going down, certainly this rib on the left looks abnormal. It doesn't look like the other ribs. So we have the expansile rib lesion. It's a very long lesion going out and expanding the rib. And this is their pelvis, and once you see the pelvis, the answer is clear. So there's multiple lytic lesions throughout the pelvis and the proximal femurs. Here we see our classic shepherd's crook deformity. Here this is also deformity to the other femur, and it's being fixed by a rod. And there's very expansile bubbling lesions all the way throughout. So this is classic for a patient with polyostotic fibrous dysplasia. Now this patient came through the emergency room, had a chest x-ray for reason unrelated to what we're going to talk about. And so they saw this right here, overlying the apex of the right lung, and weren't so sure what that was. If you're actually quite eagle-eyed, there's another finding which will allow you to confidently say what this is without any further imaging. I'll give you a moment to look. So we have this, and this is kind of a corner shot, but if you look over here, humerus is abnormal here. So this is this abnormal contour right here. It did go on to further imaging. Here's the lateral view showing you this calcified mass, which looks as like stalk, pedunculated, rising from the scapula. Then went to CT, which shows you this pedunculated mass in continuity with both the cortex and underlying marrow. You can see cortex and underlying marrow. And so this was an osteochondroma arising from the scapula, also in a patient with multiple hereditary exostosis. This was another osteochondroma. This is a sessile osteochondroma of the proximal humerus. So if you saw this, because this is clearly an osteochondroma, you should be able to look at this and say this is probably part of an osteochondroma as well too. So multiple osteochondromas again. Here's just another view of the humerus. So not only did they had one here, they also had one coming off on the lateral aspect of the proximal humerus. Okay, so two views of the knee in a child. So this looks pretty weird. You can certainly see there's abnormalities to the distal femur and proximal tibia. You have these lytic tracts which are extending from the physis and growing into the diaphysis. This one's scalloped out the bone. There's some calcification in these soft tissues adjacent here. This is just the other view showing it. So this is typical, this appearance is typical of multiple enchondromas, and this is what the enchondromas look like in the long bones in patient with multiple enchondromatosis. What you're seeing is these kind of tunneling cartilaginous tracts which are growing from the physis and extending into the bone. So this is really just kind of a one big enchondroma, an enchondroma here. They have this very typical appearance. They're always going to tunnel from the physis into the bone, again from the physis into the metadiaphysis. So if you see this, this is really pathognomonic for a multiple enchondromas in a patient. I don't know if they had Olearis Fuchi, which one it was, but multiple enchondromatosis. Okay, so frontal lateral view of the lumbar spine. So I think on the frontal view, the findings are subtle, harder to see, but perhaps this catches your eye. So there's these multiple lytic lesions throughout the left hemipelvis. And then if you look on the lateral, you can see that clearly there's a vertebral planar deformity to one of the thoracic vertebral bodies, which is hard to see on the frontal view. So this is a vertebral planar deformity. There's a short differential for vertebral planar deformity. On that list is Mets and myeloma, so clearly this is a polyostotic process. So in this case, this patient had multiple myeloma causing the vertebral planar deformity and the involvement of the pelvis. Okay, so sagittal CT, the spine. See this corduroid appearance to the vertebral bodies. It's kind of repeated down. So this patient had multiple hemangioma. So one of these is typical of a hemangioma. They just happen to have multiple in their spine. They were asymptomatic from them. Our frontal radiograph of the pelvis. So there's this area of sclerosis in the left inferior obturator ring and maybe in the left femoral head and neck region right here. So kind of a polyostotic sclerotic lesion in this case. And again, what's common? Well, certainly sclerotic metastases are common. And this was a patient with a metastasis from prostate cancer, which is a very common cause of prostate mets. If it was a woman, certainly breast cancer mets would be top choice for sclerotic mets. Other things can do it as well too, but prostate and breast are two big ones. Okay, so radiographs. Frontal radiographs of both knees. We saw a close-up of one of these earlier. So if we take one of these lesions, we have a geographic lytic lesion with a narrow zone of transition sclerotic border, which is cortically based of the distal femur in the metaphysis, and then multiple similar appearing lesions throughout the left side, as well as the right proximal tibia and proximal femur. So if we just thought about one of these, well, what would one of these be if we describe it as such? Well, we certainly described it as a non-ossifying fibroma, right? Cortically based or eccentrically located, geographic, narrow zone of transition, sclerotic rim. It's located in the right place in the metaphysis. And so we could say, well, a non-ossifying fibroma would be a good thought for that. This patient had multiple non-ossifying fibromas in Jaffe Campanaci, which if you remember is associated with cafe au lait spots. Okay, so two CTs, a coronal and sagittal. So certainly we see the L4 vertebral body. There's a lytic process involving it. It's partially collapsed. There's also lytic lucencies in the iliac wing on the left and on the right. So a polyostotic process. So what are we going to be thinking about? Well, certainly, again, Mets myeloma, depending on how old the patient was. Here's the axial CT, just showing more of the pelvic involvement, also in the sacrum on the left. And on the soft tissue angios, we can see they have a large retroperitoneal soft tissue mass. Here's engulfing the ureters. Um, and this was a patient with lymphoma, so this was all a massive lymphoma, and then lymphoma involvement of the bone too. So we didn't really talk about that much earlier as far as the malignant things, but lymphoma is one of the other things that can give you malignant polyostotic lesions. Okay, so two views of the knee. Again, this is classic. This is an Ant Mini. You should look at this and say, well, these are really just osteochondromas in a patient with hereditary multiple exostosis. Here's this kind of pedunculated one pointing away from the joint as they do. More sessile one here, and then involvement of the proximal fibula, which we're not seeing very well here. So classic multiple osteochondromas. They all look very similar, so once you've seen a couple of them, you should start to recognize what the rest look like. Okay, so radiograph, which shows this bowing deformity of the tibia, and there's this kind of mixed sclerotic and lytic lesion throughout the tibia, proximal or distal femur, and there's a fracture through the cortex of the tibia here. There's also a bowing deformity of the fibula. So this long lesion occupying the tibia and fibula, and maybe part of the tibia and femur, and maybe part of the fibula. Um, so long lesions, long bones. We're going to think of fibrous dysplasia as multiple, so polyostotic fibrous dysplasia. In this case, and remember the two syndromes are McCune-Albright, which is in girls and associated with precocious puberty and cafe au lait spots, and Mazer-Brown syndrome, which is associated with soft tissue myxomas. All right, frontal radiograph. This one just shows this. This is not very easy to see, but just show you there was a lytic lesion here. This was actually real. It wasn't overlying bowel gas or whatever. And this was a patient with EG or Langerhans cell histiocytosis. Nothing shouts, hey, this is EG, this is typical EG about this case. This could be all kinds of other things, and if you're stumbling across this case for the first time, you're going to end up giving a wider differential diagnosis because there's nothing pathognomonic here. This one just happened to be EG in this case. Okay, so two views of the hand. Here we see these soft tissue masses and these flebulists adjacent to it. The bones actually don't look too bad here. We'd be looking for any lytic lesions in the bones. This was a patient with Maffucci syndrome, multiple enchondromatosis, and this is what the soft tissue hemangiomas look like in Maffucci syndrome. Though their hands are relatively spared, at least on this side, from any enchondromas. This is again multiple enchondromas. We saw this case earlier. There are no soft tissue hemangiomas in this case. I don't think this was a hemangioma right here, that little calcification, but multiple enchondromas in this patient. Okay, so you can look at this case. So multiple lesions. So this is their hand. So you can see there's a geographic lytic lesion. It's a narrow zone of transition occupying the first proximal phalanx. Hard to see about the border, but maybe a sclerotic border. That's just the cortex. And another one in the proximal humerus. This whole proximal humerus looks very irregular, and there's this stippled chondroid matrix in here. So this was another multiple enchondromatosis. So a big enchondroma in the humerus and multiple enchondromas in the hand. Okay. CT scan, so axial and sagittal. So geographic lytic lesion, narrow zone of transition, sclerotic border in the femur, and several in the patella, or maybe it's all just one big one. Certainly thin the cortex a lot here. Maybe there's some cortical breakthrough. Is there anything specific about this lesion? No. Statistically, if you see this in an older patient, you're going to think metastasis or multiple myeloma or something like that. Um, Again, nothing specific. Again, age is your friend. These turned out to be brown tumors in a patient with a hyperparathyroidism, but I think it would probably be hard to arrive at that diagnosis prospectively. Okay, this is a different patient. So this patient has this expansive lytic lesion involving the mandible. They've got one in the rib. And they got multiple in the pelvis. They have multiple others too, some here, um, which I'm not showing you. So again, multiple lytic lesions. And this was an older patient, so probably Mets and myeloma are going to be top of your differential. In this case, this also turned out to be a brown tumor. Patient had a parathyroid adenoma in their mediastinum, causing hyperparathyroidism, and these are all brown tumors. But maybe if you saw that mediastinal mass and you were able to think that, hey, could this be a parathyroid adenoma and causing all these brown tumors, which is probably a bit of a leap because probably not your first thought. If you see a mediastinal mass and multiple bone lesions, you're going to think some kind of scary malignancy in Mets, but nonetheless, that's what this turned out to be. Okay, two views of the knee here. This is not a bone tumor in this case, but something that can mimic a bone tumor. Here you have these sclerotic serpentine lines in the proximal tibias and distal femurs. Sorry, this is artifactual here, kind of blown out. But these were bone infarcts. Bone infarcts can occasionally mimic enchondroma, but if you see this kind of classic serpentine morphology, you can just really say these are bone infarcts and be done. This one is kind of a Valentine's Day infarct, a little heart shape there. Okay, so two CTs, same CT, just bone windows and lung windows. So lots of stuff going on in the lungs, these reticular nodular opacities and more focal areas of consolidation. And there's a geographic destructive lesion involving the posterior rib right here. This has a wide zone of transition, looks scary and aggressive. I'll show you the rest of them. They had multiple lytic lesions in the pelvis, as you can see, in their skull, in their spine, causing a compression fracture. One here. So I think you certainly look at this and you say, hey, does this patient have some kind of lung cancer that's just diffusely metastasized throughout their lungs and giving them bone mets? And that's certainly probably the first thought you're going to jump to. This patient was very sick and they were septic and they cultured these things and these were cocci. So this was diffuse osteomyelitis, diffuse systemic coccidiomycosis infection causing osteomyelitis and mimicking metastasis. All right, we saw this one earlier. Again, long lesion, long bone, bone deformity, typical fibrous dysplasia. So something like this, you can really have a good shot at saying, hey, this really looks like fibrous dysplasia. So polyostotic, right? It's also involving the fibula. You saw this bone scan earlier. This was the metastatic osteosarcoma from the one that was in the tibia. Uh, This is another one, so we'll take this lesion right here to describe it, even though there's another one right here and probably another one right here. So geographic lytic lesion, narrow zone of transition, sclerotic border, which is eccentrically located in the metadiaphysis of the distal femur. There's no periosteal reaction. There's no pathological fracture. Typical appearance for a non-ossifying fibroma, right? So, assuming they're in the right age, if this patient were 80, I'd maybe think about it a little longer. There's another one right here. So this was a patient with Jaffe Campanacci and multiple non-ossifying fibromas. All right, radiograph of the hand showing multiple of these punctate sclerotic densities all throughout the hand and wrist. So typical appearance of osteopoikilosis, look like little bone islands. Um, you don't need to go to further imaging. You see this. This is really pathognomonic for osteopoikilosis. There's no malignant potential for these. Okay, so here we have our classic dripping candle wax on the femur, right, running along here, and there's also this diffuse sclerosis involving the finger. So this was a case of mallariostosis. This is the classic description, the classic dripping candle wax, and this is not as classic of appearance, but this was the same patient. This kind of sclerosis, this dysplasia along the sclerotome. This is mallariostosis. Okay, 3 cuts from the same CTs, multiple lytic lesions. These are scary lesions, right? There's some cortical breakthrough and cortical destruction associated with them. They're geographic, but they probably have a wider zone of transition, one here as well too. So we're going to think scary things. Again, what's common? Mets, myeloma are common. These turned out to be metastasis from breast cancer. Frontal radiograph of the pelvis. There's multiple sclerotic lesions, right, all throughout the proximal femur and pelvis. So just diffuse sclerotic lesions. So what are we going to think of? Diffuse sclerotic lesions, most common, would be diffuse blastic metastasis, and of those, breast and prostate are the most common. So this was diffuse prostate metastasis.